Dr. Jason Satterfield is assistant professor in the Department of General Internal Medicine, and he's also director of the behavioral science component in medical education. And as we'll see in a minute, that's a huge, huge job he has to do. He received his PhD from Penn State University, or am I saying that correct? University of Pennsylvania, sorry. And has many interests, many of which revolve around depression. So how do we look at depression? How does a depression affect illness? And in fact, that ties in nicely with what we learned about 2 weeks ago when Dr. Hamilton showed us some data how people who just had a heart attack, if they were also depressed, it really affected how well they did. So Dr. Satterfield knows all about those sorts of things as well. As we like to model this course on what our students in the medical school see, and our students are very lucky that we're not just teaching them basic sciences, but we also have faculty like Dr. Jason Satterfield. Because as we are busy trying to teach them all the techniques and all the anatomy and all the basic science, in the end, our students need to become not just technicians, but really healers who understand our patients. And so Dr. Satterfield's role as director of behavioral medicine is make sure this content and these skills are taught to the first-year students, the second years, the third years, the fourth years, and also to the residents. So if you encounter a really nice doctor who trained at UCSF, you have to thank Dr. Jason Satterfield. So having said that, let's go and listen to Dr. Satterfield.
Great, thank you. Thank you, and welcome to everyone tonight. We're going to be talking about a fairly broad and I think fascinating field, looking at the relationships between our emotions and our health. We'll also be looking at different potential interventions to manage our emotions that we believe can have important health consequences. Just to give you a sense of where we're going to be going today, I'll be talking for about an hour to hour and 15 minutes. We'll have about 20 to 25 minutes for questions after that. We're going to start off talking about some of the basics around emotions, calibrating our language. We'll do a quick run through some of the physiology, how emotions affect our body. We'll go through stress basics. We're all, I believe, familiar with stress. We know what it feels like. We'll talk a little bit about how to cope with it and how it's related to disease. We'll then look at some specific examples. We'll look at stress and immune function. We'll look at anger and cardiovascular disease, and we'll look at depression and a number of different physical illnesses. So first we should talk just a little bit about what are emotions. We all have emotions. In fact, we believe that most animals have emotions, at least in some rudimentary form. I first wanted to distinguish the difference between emotions and feelings. And I sometimes slip and use those two interchangeably, but they're really different. We think of emotions as fairly basic, body-based processes that are fairly old in terms of evolution. They've evolved in fairly central centers of our brain called the limbic system, and I'll be showing you some pictures of the limbic system in just a few moments. In contrast, feelings are something that involve higher cortical functions. So there is an emotional charge, there's a physical component to a feeling, but there's also a cognitive overlay. There's beliefs, there's values, there's ethics, there's morality, there's predictions about the future that's linked to memories in the past. So it's really much more complex, and we believe that only humans, and some people would also say higher primates, have feelings. Emotions, though, are really the basic building blocks that we're going to be talking about today. So why would we have these basic building blocks? We believe they're there for a reason, and their primary function is to communicate important information that helps us function in the world. That information might be about our relationships with other people. You love or are drawn to another person. It might be about particular situations. You are afraid of heights. You're afraid of dogs, so they actually push you away from those situations in an attempt to help you. So we think of emotions as either pulling you closer to something or someone, or they push you further away from something or someone. Sometimes they are absolutely adaptive and they are helpful. They're right on the money. Our intuition is dead on. Other times it's a misfire. It's simply not a good use of energy. It's a misinterpretation of a relationship or a situation. We do believe that emotions are universal, and by universal, it means that regardless of the country in which you were born, your education level, your racial or gender background, we all have these same sort of building blocks of emotions. Some of the work done by Paul Ekman, who is also here at UCSF, he's a psychiatrist. This was work done in the 60s and 70s, where he actually began looking at facial expressions. He took pictures of different facial expressions around the world to different cultures and asked people to tell him stories in their native language about what just happened to that person. From the results of those studies in various different cultures, he deduced that there are 6 primary emotions: happiness, surprise, sadness, anger, disgust, and fear. Now, we obviously have much more complex emotions and certainly much more complex feelings than that. He makes the analogy of painting or of thinking about colors, where we have a very small set of primary colors, but you can blend those colors together in an almost infinite variety of different shades to create the beauty of a painting or the beauty of the emotional richness that we have in our relationships. So I'm not going to show a lot of brain pictures. I think it's much more interesting to tell stories about people and how our brains are working. But just to give you a little bit of an orientation of when we talk about emotion, sort of what's happening in the brain and where it might be happening. Some of you may have seen this already, but just to remind you, over here on the left-hand side, this is if you were facing your left. The eyeballs would be about right here or so. This is a picture of the outside. Over on the right-hand side, this is a brain that has been made transparent on the outside. We're looking through to the center. This sort of golden-colored areas are the limbic system. And I just wanted to point out a couple of key areas in the limbic system. The first I wanted to point out is the amygdala. It's this little almond-shaped structure here. And I think of the amygdala as the brain's homeland security system. So it's meant to detect threats. It's meant to be helpful and to help you face dangers. However, the alerts are often so vague, contain so little information, that it gets everyone worried and you're not quite sure what to do about it. So this is your amygdala, absolutely functional at times, absolutely dysfunctional and unhelpful at times. Right behind the amygdala, we have the hippocampus. The hippocampus is important for memory, but also important for emotion-based memories. And the way I think of the hippocampus, it's sort of like the keyboard that enters data into the computer. So if you have an individual who has damage to their hippocampus, they often are able to retain memories earlier in life, but they're unable to lay down any new memories. The keyboard to that computer has been broken, so they're not able to enter any new data. It's also important to remember that the hippocampus is situated right in the limbic system, which is really the older, more primitive seat of the emotions. So a lot of those memories that the hippocampus is helping lay down in our brains are emotionally charged memories. The thalamus is the last structure I wanted to point out. It's this larger spherical structure in the center, and I think of the thalamus as the sensory relay station. So it sometimes copies, divides, and sends out different signals, visual signals, auditory signals to different parts of the brain. What happens, we really have several different areas of our brain that try to interpret data, both for emotions and also for other content. We have our limbic system, which has its own sort of quick and dirty, fast response system. And then we have our frontal lobes. And really what makes humans humans are our frontal lobes. We have these massive frontal lobes in comparison even to chimpanzees or other primates. And the prefrontal cortex, which sits about here, is probably the youngest and the most advanced part of our brain. And that part of our brain, it's responsible for impulse control, it's responsible for delayed gratification, it's responsible for executive functioning, for complex decision making, for really weighing through the pros and cons of a very complex, difficult, and probably emotionally charged decision. It's important to remember that these systems don't operate in isolation, so your limbic system, which would be in the center here, is very much in communication with your frontal lobes. Your frontal lobes are slower, they're much more advanced, they're much more complex, but they're a little slower. So a typical sort of emotional communication between the limbic system and the frontal lobes would be that blip of initial anger when someone, say, cuts you off or yells at you for no good reason. Your frontal lobes then can either amplify that sensation of anger. You start to imagine what you're going to say back, or you start thinking about the last time they did it. It amplifies the emotional sensation. Or the frontal lobes can dampen that emotional sensation. They're saying, well, probably wasn't directed at me, maybe they had a bad day, we're all just trying to get home after work, and it really, again, sort of turns down the flame on the anger. But it's that relationship, that intercommunication between the limbic system and the frontal lobe, that's important in helping us to understand why some emotions get bigger and why other emotions die out relatively quickly. It's important to remember, too, that we can think about emotions not just as these physiologic constructs. We can take some pointers from the field of psychology and think about emotions as a body-based process, but also look at their interrelatedness to both thoughts and behaviors. In other words, the way you feel, your emotions, are going to affect the way that you think. And by thinking, that means what you remember, what you selectively attend to that's in your present, what you imagine might happen in the future, the images that come to mind, even the songs or images that might come to mind. They're affected by the way that you feel and vice versa. Your emotions also affect what you do, so the behavioral choices. That's what you do at work, who you talk to, how you spend your free time, your hobbies, even the minute activities from how long you take a shower to maybe the more planful activities like taking a vacation with friends. But they're all interdependent with emotions, thoughts, and behaviors. A psychologist would say, yes, we can physiologically change your emotions by giving someone a tranquilizer, by giving someone an antidepressant. But we can also change your emotions if we change the way a person thinks, or if we change the way a person behaves, changing the behavioral choices that they make. A little bit later, we'll talk about cognitive therapy and how it has been adapted. That exact same triangle has been adapted to help people manage and change their moods. If we explore a little bit further about the function of emotions, they have different emotions, they serve different purposes, and they have different needs. In general, they cause us to approach or to move closer to someone or something, or they push us further away, but they're much more specific than that. Cognitive psychologists talk about the different cognitive themes behind some of the emotions, and these are just a couple of examples. A person tends to feel the emotion of anger when there is a perceived violation, injustice, or a frustration of their wish or desire. That's usually the thought or the theme that's paired with the emotional sensation of feeling angry. It's not to say you're right. It's not to say that it's even particularly rational. But if you were to pull out the cognitive content that's related to that feeling, that's what it would be. For happiness, it's usually the perception or the expectation of gain. It could be physical gain, it could be emotional gain, it could be a symbolic gain. Anxiety or fear is really two different things. It's the perception of threat, there's something dangerous that's out there, coupled with the belief that you might not be able to face it. So there's something dangerous out there and it might get me. I can't run fast enough, I can't fight it. So you feel the anxiety or fear. Sadness is a perception that something of value has been or will be lost. And we're not talking about clinical depression here, we're talking about sadness or the everyday depression that all of us feel. The question still remains, though, about emotional triggers. We've all had these emotions at some time or other. We all may have very different set points. Some people may be intensely emotional. Some people might not be as emotional, have sort of a more stoic presentation. You may know some people that are very prone to anger, some people that are very joyful and full of laughter, some people that tend to be kind of prone to sadness, the Eeyores of the world. So the question then is what is it about our environments, or what is it about us that cause us to be drawn or to gravitate towards one emotion or the other? So I thought we would just do a quick exercise. I'm going to show you some pictures. I think it's about 6 pictures or so. They're just of various things, and I want you to write down the emotion it evokes in you. Okay, so there's no right or wrong answer. I'll ask for a few volunteers when we finish the 6 pictures to share what you wrote down. But just jot it down in the margins or on a piece of paper. I'm going to show you 6 pictures, and I want you to write down the emotion it evokes in you. Okay? So here's picture number 1. So what emotion does picture number 1 evoke in you? How do you feel when you see that? I just write that down and we'll come back to it. Picture number 2. What emotion does that evoke in you? There's no right or wrong answer, just about your experience. Picture number 3. What emotion does this evoke in you? Picture number 4. What emotion does this evoke in you? And picture number 5. It's always good around dinner time, right? What emotion does this evoke in you? Okay, we have one more. Picture number 6. What emotion does this evoke in you? All right, let's go back up to the top and let's see what folks had. So how about some volunteers? Just raise your hand and tell us what the emotion you wrote down for this one. Yes, in the back. Happiness. Tenderness. Indifference. Okay. Yes, in the back. Joy. How about a fatigue? Is there a So it's a fairly emotionally evocative picture, but we still have a range from indifference to joy to happiness. Let's look at the second one. A little bit different picture. So what did people feel? Yes? Sadness. Fear. What else? 911. Yes? Surprise. Help. Right, so this sense of urgency, there's something that's going on. Confusion. Right, so there's confusion. Sometimes when we show this picture, we get annoyance, because people think, oh no, now I have to do something. Yeah. No, it's what you're feeling. So it's just what you're feeling, your emotional experience. So this is a picture actually from a Marin County breast cancer campaign. And the tagline was, "Women are dropping dead and no one cares." So it was meant to be certainly evocative. Okay. We still have, same stimulus, a range of responses from you guys. How about with this one? A little more ambiguous about what it is. So what did you feel? What did you feel when you looked at this picture? Yes? Confusion? Curiosity? Yes? Vague? It's vague. Okay, it is vague. What else? Fear? Uncertainty? Sadness. So we have a pretty big range of different emotions. We're all looking at the same picture here, but we're feeling different emotions. And I would say the physiological processes that are going in our bodies, although fairly small, these aren't super intense feelings, those physiological processes are different. This is a picture from an art therapy group in a psychiatric inpatient hospital. And it's a patient who's clinically depressed, and it was a pictorial representation of his depression. It's actually a male figure sort of walking through this darkness. How about this one? Anxiety, fear, worry, humor. So we're getting a range again, looking at the same pictures, but we're getting a range. I'm getting a little more of an anxiety flavor from most people. This is a picture from a social phobia workbook. And it's meant to, it's called scrutiny. So people are supposed to feel self-conscious when they look at that. How about this one? Whenever I've shown this picture, I usually get about 98% disgust, but there's always 2% of something else, and I wonder if it's here. Curiosity, that's close, yes. Awkward. So there's a humor. People see, and maybe it's because she's kind of grinning and laughing. Some people find it humorous. Most of us, I think, is kind of gross and disgusting. But this is a high school science teacher, and she was doing a demonstration for her high school science class about how bugs are our friends. So I'm not sure about the one going up her nose, but... And how about the last one here? So this is certainly more ambiguous. What are the feelings? Intrigue. Fear, surprise. Others? Interest. Interest. Yeah. Content. Okay. So pretty big range of responses, different emotions, different physiologic signatures associated with those emotions. Our bodies are doing different things. Our limbic systems are doing different things. Same stimulus that's here. What's happened is that whenever our environment gives us less data, whenever whatever we're looking at or hearing is more ambiguous, we have to insert more of our subjective selves into it. We have to make our own read of what's going on. We have our own interpretation based on partly that ambiguous stimulus, but also partly on how we just happened to interpret it. It's kind of like a Rorschach ink blot. So the whole idea was based on the fact that the more ambiguous the stimulus, the more of your personality you have to use to have a response to that stimulus. This is actually a fairly well-known picture by Magritte called The Healer. And I won't interpret it. I can interpret art however you want. So the question was, what emotion goes with whimsy? I would just say, I don't know if it's an emotion or a feeling, but enjoyment, pleasure. So what we've done in just sort of a quick, fun demonstration is to show that we can all experience the same stimuli. In this case, it's a set of slides, it's a set of pictures. We can have a very different emotional reaction. And I would push that a little further to say that we might even have our own set of emotional habits, our own leaps of faith that we make in trying to interpret different situations in our world. Some of us may leap to anger, some of us may leap to pleasure, some of us may leap to curiosity, some of us may be sad, some may be anxious. It's not to say that it always happens that way, but I think knowing your emotional habits is important in understanding why you get stressed or not in certain situations, and in understanding your potential risk for disease. If you're a person who's more prone to hostility or more prone to depression, there may be different physiologic consequences as a result of that emotional habit. So let's talk about what some of those consequences might be. I first wanted to do just a quick run-through of some of the history of what I'm calling mind-body medicine. And the mind part of mind-body includes emotions, it includes cognition, sort of the things we've been talking about already. And I think in this day and age, it's a fairly well-accepted notion that the way you feel or the stress that you experience affects the way your body functions. It makes sense. Your brain is an organ in your body. All of your organ systems are connected. So if something's happening in your brain, it's probably going to affect the rest of your body, and vice versa with all of the other organ systems. But it took a while for us to really get to that point where we're able to say, I think with fairly good certainty, that we're beginning to understand how stress, how the physiologic manifestations of stress affect our bodies. How this story began to unfold, I actually start back around World War I, or as World War I was ending. There was not at the time this concept of post-traumatic stress disorder, or what eventually became shell shock. It just didn't exist at all. This notion of mind affecting body wasn't something that was well accepted. So as the soldiers began to come home from Europe, to the UK and also to the United States, they had seen a lot of a fairly horrific conflict and combat. A lot of them had post-traumatic stress disorder. We didn't know what that was at the time. Unfortunately, they were accused of malingering. They were denied their benefits in the United States, and in the UK, they were actually charged with crimes and jailed for malingering. There was a huge public outcry to this, as you might imagine. A lot of federal funds here and in Great Britain were pushed towards looking at what is this new malingering syndrome. They eventually called it shell shock, where they talked about how a person's physicality, their body could be intact, but because of the psychological damage of war, they were experiencing physiologic symptoms when they came back. It, of course, launched this whole field of study of looking at what eventually became post-traumatic stress disorder through these different series of steps that I've outlined. In the 30s, we had Hans Celje doing some of his seminal work looking at stress responses in rats. He discovered them quite by accident. He was an endocrinologist who happened to be a fairly terrible lab technician. So he often dropped his rats, he didn't feed his rats, he was giving them injections and he would break the needle. He was essentially a dope in the lab. He discovered, much to his surprise, that all of his animals developed what he called a general adaptation syndrome. They were essentially developing ulcers, they were developing tumors, they had enlarged thymus glands, they had all of the effects of what we know as the chronic effects of stress. Fortunately for him, the light bulb went on. He was not charged with animal cruelty, and he went on to really essentially found the field of mind-body medicine. Fast forward ahead to this day and age. Fortunately, a lot of the groundwork done looking at the relaxation response, or the opposite of stress, the counter response to stress. Complementary and alternative medicine really coming into the forefront of our consciousness in the 90s. And now we're using a term called integrative medicine, where finally, lo and behold, we're realizing that we need to not just talk about an individual as if they are a collection of cells, but they are a human being with personalities, with psychologies, with emotions, and with spiritualities even. And we're realizing that in order to truly understand health or disease, we need to understand the interrelationships of all of those. Let's take a moment just to review some of the basics of stress and why person A may be extremely stressed, when person B in the exact same situation may be cool as a cucumber, no stress whatsoever. In order to understand those differences in responses, it's important to know what's happening cognitively, or sort of the middle step. So first, you have a potential stressor. Let's say that you have to study for an exam. Stressful for some people, not stressful for others. When an individual is told they have an exam, a couple different things would happen. They first make a primary appraisal. Does the test matter? Do exams really matter? Do I really care about my grades? Is this going to be a big deal or not? The secondary appraisal is their estimation of their capacity to cope. Am I a good test taker? Do I know the material? Do I know how to study? Can I cope with this potential threat that's on the horizon? It's the combination of primary and secondary appraisal that helps us understand who has a stress response and what magnitude stress response that's going to be. If you believe it's a hugely important event, your primary appraisal, you have no resources to cope with it, you're going to have a fairly robust stress response. And remember, with a stress response, we're not just talking about something that's physiologic. We're also talking about changes in cognition. When people are stressed, they develop a sort of tunnel vision and cognitive inefficiency. They have emotional responses. They may become angry or irritable, and maybe behavioral consequences, and we'll talk about some of those. When we talk about stress and disease, it's important to remember that there are three pathways that stress can be related to disease. They are not mutually exclusive. In fact, I think all three of them are often at work. So we have this experience of stress. It can affect you through the direct physiologic effects, and we're going to walk through two different stress response systems that can affect your body. It can be health habits. Unfortunately, when we are stressed, we tend to do the exact opposite of what we need to do to counteract the negative effects of stress. When people are stressed, they sleep less, they eat worse food, they drink more alcohol, they smoke more cigarettes, they do less with their social supports. So in general, they're amplifying the negative effects of stress. This last category here, the health behavior effects, I really think of that as medical compliance. Oftentimes people who may have been quite successful, let's say managing their diabetes, have a fairly substantial stressor that comes along, and suddenly they stop checking their blood sugars, they fall off their diet, and they stop keeping their doctor's appointments. And you may have all three of these pathways contributing to the advancement of their disease: the physiologic effects, health habits, and healthcare or medical utilization. So I mentioned I was going to talk about two different stress response systems, These are the physiologic stress response systems. One is relatively quick and dirty. It's relatively short-lived. The other is slower to start but lasts much longer. So first, I just want you to look over to your right. So over here on the right, you have this stressor, this perception of stress. It starts in your brain. You have to notice something. You have your primary and your secondary appraisals. You have the activation of what's called SAM, or the sympathetic adrenal medullary system, SAM, the sympathetic adrenal medullary system. And just think of this as the fight or flight response. We've all had that before. We've had that surge of adrenaline. Your heart rate goes up. You feel a little tense. You feel a little on edge. Your body is preparing you to either fight or flee. Very adaptive, simple mechanism. It can happen in an instant, but it also fades fairly quickly. On the left-hand side, to your left, we have something called the HPA axis. That stands for hypothalamic, pituitary, adrenal axis, so HPA axis. It's much slower, but it lasts a lot longer. And instead of using adrenaline, it uses a stress hormone called cortisol. Now, we've all probably heard of cortisol before. We need it. It helps us to regulate our blood pressure and cardiovascular function. It also helps us in storage and retrieval of energy. But if you have too much cortisol in, say, prolonged stressful periods, we also know that it can have negative health effects. Now, let me just say one word about this unfortunate individual. He has one adrenal gland. It's in the center of his abdomen. This is not anatomically correct. Your adrenals actually sit on top of your kidneys, so you have two adrenal glands. So this was just for the sake, I think, of making it a little more simple. I know you've heard some about depression and cardiovascular disease and maybe some about stress and cardiovascular disease, but I just want to walk through this map maybe in a little more detail of how those two stress response systems, the sympathetic adrenal medullary system, fight or flight, and the HPA axis, cortisol, can be related to, say, having a heart attack. Now, we know from the epidemiologic literature that there's a number of, at first, bizarre phenomenon that happen. And really the only way we can explain them is to look at the relationship between psychological stress and cardiovascular disease. Some of those bizarre phenomenon are more heart attacks occur on Monday than any other day of the week. There's no real good physiologic reason for that, other than people tend to go to work on Mondays, and there's a lot more work stress on Mondays. There are more heart attacks and reports of chest pains following large stressful events. If you look at the number of heart attacks in New York after 9/11, they actually skyrocketed. If you look at the number of heart attacks or reported incidences of angina or chest pains, they skyrocketed after the Loma Prieta earthquake. So again, there's no good physiologic reason for that unless we look at the relationship between stress and cardiovascular physiology. So if you just move from left to right on this figure, you start on the left with mental stress. It can be real or imagined. You're making your appraisals. It causes the activation of the sympathetic adrenal medullary system, that fight or flight. Activation of HPA, you get cortisol. You get a surge of catecholamines. This is norepinephrine or adrenaline. It causes an increase in heart rate, causes an increase in blood pressure. So your body's really gearing itself up to face this perceived threat. Now, it's a little bit different, though, in a person who has pre-existing cardiovascular disease. They already have a system that's damaged. Either their heart muscle has been damaged, maybe they had a heart attack before. Their blood vessels may have been damaged. They may have hardening of the arteries. They may have already developed some plaques or possible occlusions of their arteries that have narrowed or limits the amount of blood that can reach tissues in need. What happens, so here's our background factors here. What happens is as the system is gearing up, your heart's beating faster, your blood pressure's going up, cardiac demand is going up. So your heart tissue just needs more oxygen to work harder. Unfortunately, if you have this pre-existing disease, either your vessels cannot dilate to increase supply to meet that demand, or you may have something called paradoxical vasoconstriction, and people who have diseased arteries can have that at times. So instead of dilating, they will actually constrict. What's happening is your demand is going up, up, up. Supply is not meeting demand, so your heart is starting to get starved for oxygen. It's creating what's called an ischemic environment. If you have an ischemic environment, it causes more electrical instabilities. Your heart loses its rhythm. It's a fairly complex and coordinated rhythm. A person may have an arrhythmia. They may have an arrhythmia that's here of ventricular fibrillation, or their heart starts beating really quickly. They're in their ischemic environment. Other things that might happen, those plaques may actually rupture and break free. They move further downstream and may completely block a particular vessel. The story is getting worse and worse. The picture's getting more grim. The heart tissue is becoming more and more starved for oxygen. And eventually you have an outcome like a myocardial infarction, or you have a heart attack, where the oxygen supply is cut off and the muscle tissue actually starts to die as a consequence. So the comment was about some preventive measures, and especially if you are a person that has some of these background factors, it's important to consult your primary care physician, to consult your cardiologist. And aspirin, nitroglycerin, there's a number of other things that you can take to try to counteract these effects, to increase the supply that can meet the demand that may result from psychological stress. There are ways to fight back. You're right, and we're going to go through some of those ways. That's the relationship between stress and cardiovascular disease. I wanted to talk a little bit about the relationship between stress and immunology. And I wanted to talk about a relatively new field of psychoneuroimmunology, or the relationship between how psychological states, like emotions, are related to how well our immune system functions. And to do that, we just need to do a quick run through immunity. Very complex, very elegant system. I think it is the unsung hero of medicine and of med schools. But I want to just, to not do it justice, but to do a quick run through these two different systems that can be affected by both acute short-term stress or chronic stress. So if we think about our immune system, really our best immune organ is our skin. So it's absolutely the best at keeping out pathogens, so keeping out bacteria, viruses, fungi, whatever it might be. But things happen. Either we have mucous membranes that absorb a bacteria, or we get a cut or a breach in our skin. And what happens is, on the left-hand side, we get these invading pathogens. Now, we have a first line of defense, these free-floating immune cells like natural killer cells or phagocytes that are fairly generic and fairly effective killers. So they will kill anything that isn't identified as part of you. This is part of what happens if you have an organ transplant. That organ is not part of you, and your immune cells start to try to kill that organ. They're not particularly intelligent. They just try to kill anything that's not labeled as you. There are a few particles, however, that manage to slip through the first line of defense. Unfortunately, this system, this elegant system, has a backup. Some of these cells actually break off parts of this pathogen. They carry them back to our lymph nodes, to our spleen, to our thymus, and they tell the second line defense, here's what just invaded. You guys get to work. You need to start making some specific immune cells that seek out and kill just these pathogens. So this is a much more specific but much slower backline immune system. The downside of this is it takes 3 to 7 days for this second line of defense to kick in. So we have our first line of defense. Those cells are already there. They're already freely circulating. They do most of the work, but oftentimes this backline defense takes up to a week for it to kick in. Needs to adapt cells to specifically and more effectively kill these pathogens. So if you want to look at the relationship between stress and immune function, then you have to ask yourself, does stress exert its effect on the front line immunity, or does it exert its effects on the back line of immunity, or maybe both of those? So researchers have had all sorts of fun trying to figure out this relationship. Yeah. So that's a good question. So the question was, where do antibiotics come in? So antibiotics, there's broad spectrum antibiotics and there's very specific antibiotics. Depends on the type of bacteria that you have. So usually there will be a screen of some sort to decide what type of bacteria you have and what family of antibiotics would be most important. You take those antibiotics, and I think of those antibiotics as more similar to backline defenses. They're specifically designed, or at least designed close enough to kill that specific bacteria that you've invaded. For particular kinds of bacteria, they just don't work at all. You have to be prescribed the right antibiotic. And you may have had the experience, you took a full course of antibiotics, didn't do that much good, because it wasn't the right antibiotic to affect the pathogens that you actually had. Okay, so researchers have had all kinds of fun trying to look at this relationship between stress and immune function. One of the earlier studies done was by Sheldon Cohen, and he wanted to start with this notion that stress makes you more susceptible to catching a cold. And I think a lot of people believe that to be true, but he wanted to test out whether or not that common sense model is actually true or not. So what he did was recruit about 400 subjects. He got them to sign a consent form saying that they were willing to have a rhinovirus or a cold virus squirted up their nose. And they were willing to fill out a bunch of questionnaires and personality measures. He wanted to look at the relationship between how stressed are they when I squirt that virus up their nose and who goes on to catch a cold. He also, to try to control for as many external variables as possible, he had them quarantined in a hotel room for up to 3 weeks, depending on how long their cold lasted. So he didn't want them to be exposed to other viruses from other people. Squirt the virus up their nose, lock them in their hotel room, send them room service all the time. So maybe it wasn't that bad to be a subject in this study. He also wanted to have a fairly objective measure of how severe the cold was. Subjective reports are important, but he wanted to be more objective. So he asked them to save all of their bodily secretions, all of their mucus, if they coughed anything up, every time they blew their nose, everything had to be saved. And it was weighed and it was measured, and they examined it for viral shedding or the number of viral particles that were in those different secretions. So he had subjective reports, but he also had some fairly objective, albeit somewhat grotesque methods to be a little more precise. What he found is pretty much what we knew already. When we are really stressed, we are more susceptible to catching a cold. When we are really stressed, the cold that we catch is more severe and it lasts a lot longer. So yes, indeed, common sense again proves to be true. A slightly different approach was used by the Keycolt Glazers, Janice and Henry, who are in Ohio. They wanted to look at stress and wound healing. Of course, it involves immune function, it involves inflammatory responses, sort of a more sort of complex level of looking at immune function and stress. They went to students, and they actually went to dental students, and they got a relatively small sample of dental students that were willing to have a hole punched in their hard palate. So that's kind of a small, but I would think somewhat painful injury, a wound, and then they would come back every day and they would measure how well that wound was healing. And this is just a picture of the wound, and the center part hasn't healed yet, and you can see the pink part that has actually healed already. The idea was they would actually make 2 different wounds. They were going to puncture their hard palate in the summer when there was no school, no exams, relatively little stress, and then they were going to puncture their hard palate again right before exams at the end of the fall semester. A lot more stress. They figured it would take a lot longer. The thing that was clever about this study is that each subject can serve as his or her own control. They've had 2 holes punched, so they looked to see how long did it take John's injury to heal in the summer versus how long did it take John's injury to heal when he was near exam time. And they could compare every subject that way. So this is what they found. The dark bars are, these are the number of days it took to heal. The dark bars are low stress periods, and the striped bars are high stress periods. So you can see for every subject, every single subject, it actually took longer to heal when they were in a high stress period. Now for some of these, like this subject here, it doesn't seem like a huge difference. For others, like this subject here there's really a large difference between how long it took to heal. Now it doesn't take a lot to extrapolate this to, say, surgeries. Now there are wounds that are certainly inflicted when a person has surgery. I think one thing that we should be doing before a person goes to surgery is measuring their stress levels, and if they're stressed, putting them through some fairly effective and intensive stress reduction measures before the surgery and then after the surgery if we want to minimize the time it takes for them to heal. In general, the summary of the field of psychoneuroimmunology is as follows. Short-term or acute stress temporarily improves frontline immunity, but it suppresses backline immunity. And if you think of that from an evolutionary perspective, if you're in a fight or flight situation and you get injured, you get cut, you get bitten, you want that all your energy, all of your limited resources up front to try to kill what are the pathogens about to invade your body. You only have limited resources, so you have to take that energy from the backline immunity to beef up your frontline defenses. It's a different story, though, when we have chronic stress. Chronic stress suppresses frontline immunity. It also suppresses backline immunity, our second line of defenses. Our bodies really weren't made for these chronic stressful states that we find ourselves in these modern times. We were made for fight or flight. We were not made for chronic 9 to 5 stress day after day after day after day. But that's what our bodies are trying to adjust to now. Now, a completely different set of emotions, but something that I think is certainly related to stress and certainly has an important physiologic consequence is anger. And in particular, I want to talk about hostility. But to do that, I wanted to take a step even before that and talk about some of the research by Meir Friedman. He's here up in the corner. He is a cardiologist in San Francisco, founded the Meir Friedman Institute. He actually had a rather tawny private practice, I believe in Pacific Heights, for cardiology patients, saw a rather wealthy clientele. He discovered type A personality quite by accident. Again, he wasn't particularly interested in mind-body medicine. He was interested in having nice furniture in his waiting room. So he invited a furniture upholsterer to his waiting room. He thought his chairs were looking a little worn. The upholsterer took measurements and counted the chairs and was going to give him an estimate, gave him the estimate and said, well, you know, Dr. Freedman, I don't mean to pry, but I have to ask you, what kind of patients do you see? This is the most bizarre wear pattern on the chairs. I mean, it's not the top that's worn, it's the front of the arms, like someone's fidgeting their hands all the time. It's the front of the seat, like someone's bouncing their legs up and down all the time. You must really have some agitated people who come here. Meir Friedman had the light bulb go off for him, and he realized, wow, the guys I see, and it was mostly men that he saw in his practice, the men that I see here are really kind of irritated and impatient and angry and driven and competitive. What he eventually called, for unknown reasons, type A behavior pattern, which he defined as a behavioral and emotional style marked by aggression, an unceasing struggle to achieve more and more in less time, often in competition with others. He identified sort of 3 important elements to that: easily aroused hostility, time urgency, and competitiveness. So easily aroused hostility, time urgency, and competitiveness. Now, since then, there have been a number of studies trying to pull apart which of those factors are most important in terms of understanding its impact on our health. And it seems like the only one that really carries any punch is easily aroused hostility. So if you're a little urgent about time, no worries. If you're a little competitive, no worries. If you're someone who has easily aroused hostility or cynicism, then you might want to pause. So how do we measure hostility? This is the Cook-Medley hostility scale. It's actually a much longer scale, but I just wanted to give you a little bit of a flavor of some of the items. These are all answered true or false. First question is, no one cares much what happens to you. True or false? I've often met people who are supposed to be experts who are no better than I. True or false? Some of my family have habits that annoy me very much. True or false? People often disappoint me, or it is safer to trust nobody. Now, if we're honest, I think we all get a few points. On the Cook-Medley hostility scale, what's typically done in research studies is they will take the top 25%. So the quarter that scores the highest on the full measure. And it's those individuals that they look at to see what the physiologic consequences are of being hostile often. There are actually over 2,000 studies now linking hostility to cardiovascular disease, so I'm clearly not going to present all of those, but just wanted to give you a couple of studies that I thought were especially noteworthy. One is by Karen Matthews. This was published just a few years ago. This one's noteworthy because she looked at such a young sample. She looked at students that were 18 to 30 years old. Now, we don't think of cardiovascular disease in people who are that age. And in fact, they didn't have cardiovascular disease. But she knew that even at that age, you might show some precursors for later cardiovascular disease. And in particular, she was interested in coronary calcification, so laying up calcium deposits in your arteries, which paves the way for hardening of the arteries later. What she found is that hostility in 374 young students predicted calcification of their arteries 10 years later. So even in that young sample, being high in hostility, 10 years later predicted calcification of their arteries. And I would say if she followed them 20 years, 30 years, a lot of these same students would be the ones who are having heart attacks in their 40s and in their 50s. This second study I thought was notable for a few different reasons. There was a lot of racial and ethnic diversity. It was a fairly long follow-up, and they had some pretty dramatic findings. It was a 4.5-year longitudinal or prospective study of 13,000 white and African American men and women. They found that anger in this sample actually tripled the risk of having a heart attack, or SCD, a sudden cardiac death, even after controlling for smoking, diet, weight, all of the usual hypertension, all of the usual risk factors. So really it was this trait of anger that tripled the risk of having a heart attack. Now we're going to come back to treatment. So if you are a person who has anger, your amygdala just sends off lots of false alarms, there is a way to treat that. Major depression. So we've talked about stress, we've talked about anger, type A personality. Let's talk about depression. Remember that we think of major depression or clinical depression as a medical disease just like any other. In order to be diagnosed with depression, you have to have 5 of these 9 listed symptoms most of the day, nearly every day for 2 weeks. So it's not having a bad day, it's not having a few bad hours, it's not being overwhelmed or stressed at work. It really is this cloud that descends on an individual and stays there morning, noon, and night for at least 2 weeks and oftentimes much longer. There are mood symptoms, depressed mood, irritable mood. Anhedonia is the inability to feel pleasure, so people just don't get enjoyment out of things they used to enjoy. There's a number of changes in body systems, so your energy is off, your sleep, your appetite, you may see weight changes. And the way an individual moves changes. Many of my depressed patients will talk about depression feels like you're walking underwater. You just feel very slowed down. Or sometimes the opposite happens where they feel very agitated and very keyed up, and you can actually feel it. You can see it when you're sitting in the room with something who's like that. You see differences in concentration and memory. Changes in the way that people feel or think about themselves, often feelings of worthlessness or guilt. And you also see suicidal ideation. And we actually, I think, talk about suicide far too little in this country. It's like our dirty secret. There are far more suicides than there are homicides, yet homicides are what tend to make it on the news. A little bit on the epidemiology of major depression, and we will talk about treatment, absolutely treatable. The prevalence is about 5% or so, and by point prevalence it means if I took a snapshot of this room right now, we might see about 5% of people who would meet criteria for major depression. Doesn't discriminate on age, education levels, background, or what have you. Lifetime prevalence is about double for women than it is in men. Some people would say that that's a function of our culture. It's much more acceptable for women to say they're depressed. Women are also a lot more likely to go and to seek help when they're depressed. Men are a lot more likely to drink. So oftentimes we'll see men presenting with alcoholism when in fact the underlying cause is major depression. We think of depression as a chronic disease now much like diabetes. It is manageable. I'm not sure if it's curable. Some people have one lifetime episode and that's it. They restabilize, they don't have any more episodes. But after you've had one episode, you have about a 50-50 chance of having a second episode. If you've had 2 episodes, your risk of having a third episode is about 70 to 80%. So it's almost like the disease picks up steam. The way I think about it is neurons that fire together, wire together. So you have that first episode, there are these depressive pathways laid down. Each episode broadens those pathways and makes it easier to get depressed again. There is treatment. Remember, though, we're not just thinking about this from a biomedical perspective. The way you feel, your depression also affects the way you think, and it also affects your behavior, the things that you do. The reason depression can be so persistent and difficult to treat is something we call the 3 downward spirals for depression. When a person is depressed, it causes them to think more pessimistically. They think of more negative things. They're less kind to themselves. As they think more negatively, it makes them more depressed, which makes them think more negatively, which makes them more depressed, and so on as they spiral down. The same with activity levels. As a person becomes depressed, they don't enjoy things anymore. They don't have the same amount of energy that they had before, so they do less. As they do less, though, There's less possibility for positive reinforcement. There's less opportunities for social support, so they get more depressed, which makes them do less, which makes them more depressed, which makes them do less. And the same thing with social contacts. When a person is depressed, oftentimes they're more irritable or they're more sensitive to feeling rejected or to feeling hurt, so they withdraw and they isolate, but that makes them more depressed. So they isolate more, which makes them more depressed, and so on. So if we want to treat depression, we want to stop these downward spirals. And in fact, what we want to do is to try to reverse them. And we can do those with medications, or we can also do those with therapies that target thinking, that target behavior, or target social relationships. Before we talk about treatment, though, I just wanted to talk a little bit about depression and its relationship to diseases. And I know you've heard some of the studies linking depression and cardiovascular disease before. Here's just a few other examples. NHANES is a National Health and Nutrition Examination Survey, a fairly large survey over a number of decades looking at different risk factors for disease. Here we see that depression doubles the risk for high blood pressures in whites and triples the risk in African Americans. It increases the risk of CHD, that's coronary heart disease, by 75% after controlling for other risk factors. So if you have a person who's depressed and you have a person who's hostile or cynical, we're not sure if there's an additive effect, but I would say that that person's risk, I would guess that that person's risk is even higher. Another interesting study, this was again going way upstream, it's called the precursor study, looking at depression in medical students. Average age in medical students, usually early into mid-20s. We see that the depression in medical students predicted coronary heart disease, and this is a heart attack, an MI 40 years later. So even when they're depressed as medical students, again, those neurons that fire together, wire together, the pathways for depression are being laid down. 40 years later, we're seeing a increased risk for heart disease and heart attack. I won't go through all of these. This, again, repeats what you've heard before. A number of hospitalized patients, you go to the hospital after a heart attack, they meet criteria for clinical depression. This is 1 in 5 meets criteria for clinical depression. Point prevalence for depressive symptoms, so they may not have 5 of 9 symptoms for at least 2 weeks, but they have some depressive symptoms, is much higher, it's 40 to 65%. I would say that part of any cardiac rehabilitation program needs to contain a fairly substantial depressive screen that needs to be repeated, and if that person is depressed, then they need to be treated for depression at the same time as being treated for cardiovascular disease. This is depression and coronary artery bypass graft. So this is a bypass surgery. And again, it's the same picture that we've seen before. Depression is an important variable. In fact, depression, which many think of as sort of a soft variable, is just as predictive of ejection fraction. So that's how much blood is being squeezed out of a particular part of your heart in a second. The big question, though, so we look at depression, we look at stress, we look at anger, we look at hostility. Can psychological interventions reverse this, or can they prevent this harm from occurring in the first place? And to start to think about those interventions, first we have to go back to our model of stress. Remember, we have the stressor, we have our primary and secondary appraisals. Does it matter? Can I cope with it? You have your stress response, and then hopefully that's followed by an adaptive coping response. And we think of coping in a couple of different categories. We have problem-focused coping, which is when you do something that directly tries to change the stressor. So if the stressor is you have to take an example of problem-focused coping would be cracking open your textbook and studying for the exam. But we also need emotion-focused coping. There are sometimes stressors that we can't change. We can do absolutely nothing about them. What we can change, though, is our emotional state. So an example of emotion-focused coping would be calling a friend, going to a movie, reading a novel, watching American Idol, whatever it might be, that takes your mind off that stressful event. So it decreases your thinking about it, it decreases your stress response. The most effective coper is someone who uses a mix of problem-solving and emotion-focused coping and knows when to use what type of coping. In general, if it's a stressor that can be changed, it's in your power to change it, you want to use more problem-focused coping. If it's something that you absolutely can do nothing about, you probably want to go more in the emotion-focused route. There's a variety of stress management programs, most of which work to some degree. I think it's more a matter of finding what works for you. It can be progressive muscle relaxation, it can be meditation, it can be breathing, it can be exercise, it can be all sorts of different interventions. The more cognitive or psychological stress reduction programs tend to do a couple of different things. Most of them first train people to look at their appraisals. So sometimes people who are chronically stressed are stressed out because they make mountains out of molehills. Every stressor that comes along is seen as an enormous problem. It's something that is hugely important to them, so that's their primary appraisal. So part of their stress management program would get them to make more accurate primary appraisals. Other people tend to underestimate themselves and their capacity to cope, or they just don't use the coping resources that they have. They don't turn to their family, they don't turn to their friends. So we get people to do a more realistic secondary appraisal of their capacity to cope and the coping resources they have and how to more effectively utilize those. So really, from the outset, if a person is lowering their primary appraisals and increasing their secondary appraisals, you've already gone some distance in helping them to manage their stress. Other examples would be finding what I call a healthy diet of activities. I think oftentimes we get unbalanced. You spend too much time at work. You spend too much time worrying about the bills. You forget that you need to enjoy time with friends. You need to enjoy time with families. You need to connect perhaps to your sense of spirituality. But ideally, you need a mix of things that give you a sense of accomplishment, but also give you a sense of enjoyment and a sense of connection. So just like in a healthy diet, you need a mix of your different food groups. For activities, you need a mix, a balance of those different activities. Other examples would be, I mentioned the elicitation of social support. Medical management, there are short-term medications which can help turn down the stress response that a person might be feeling. Exercise, and here I mostly mean aerobic exercise, should not be underestimated. It really helps us burn off our stress hormones. Remember, we've talked about cortisol before. Exercise really helps us to reverse those negative physiologic effects of stress. This study was done about a decade or so ago. This was a study in North Carolina where it was Stairmaster versus antidepressants. The antidepressant they used was an older one. It was a tricyclic antidepressant called imipramine. But the sample was randomized into two groups. These were mild to moderately depressed, so these weren't severely depressed folks. Half of them did a Stairmaster 4 to 5 days a week. I think it was 20 to 30 minutes or so. The other half had imipramine. They measured adherence, and then they also sort of measured their improvement in mood over time. What they found at the end of the study is there was actually no difference in terms of mood outcome for those two groups. In the antidepressant group, they had side effects of dry mouth and urinary retention and grogginess and drowsiness and so on. In the exercise group, the side effect was they felt more fit, they felt more energetic, and some of them had lost a little bit of weight. So important to remember that exercise in and of itself can be a useful medical intervention. If we go back to looking at IHD as ischemic heart disease, this is a randomized controlled trial of about 100 people who have ischemic heart disease, meaning that half of them, or they actually went into 3 different conditions. A third of them went into an exercise group, a third went into a stress management group, and the others went into a usual care group. They followed them for 3 years. At the 3-year follow-up, you see that the exercise group had a 21% recurrence of a cardiac event. So they had another heart attack, something else happened. Only 9% in the stress management group, 30% in the usual care group. Usual care was going to the cardiologist, taking a fistful of pills every day, and so on. So certainly helped in usual care versus nothing. A little bit better in physical exercise. Pretty huge difference. Only 9% in the stress management group went on to have a second event in 3 years. So how about the guy who has a problem with hostility or with cynicism? Is there a way to try to change that? This is a fairly old study, again by Meir Friedman, who initiated the concept and research into type A personality. It was a 4.5-year randomized controlled trial of about 1,000 guys who had had a heart attack. They were assigned to 3 different groups. They had a type A counseling group. They had just sort of a generic group counseling, kind of a Bob Newhart kind of group counseling. And then they had a usual care group. And again, this is the percentage of cardiac recurrence, so lower numbers are better. In the type A group, you had about a 13% recurrence versus 21% or 28% in the other 2 groups. Now, I will say that treatment for type A personality is something that hasn't really caught on, and I'm not sure if health insurance companies pay for it. The group was a weekly 2-hour group that actually met for a couple of years. And if you can imagine the group, so there's 10 angry, competitive guys who are in pain, they've just had a heart attack, and they're being told things like, always drive in the slow lane, let someone else cut ahead of you, use the computer that's the slowest. So intentionally creating exposures to situations that normally would make them mad and teaching them how to relax in the face of those frustrations. But the process is really frustrating them a lot and teaching them how to deal more effectively with that frustration. It still had, nonetheless, pretty good outcomes. If we're to turn to a more sort of systematic type of psychotherapy, one kind is called cognitive behavioral therapy. A lot of support for cognitive behavioral therapy, or CBT, for depression, for anxiety, for eating disorders, for a number of different emotional problems. And to understand CBT, we have to go back to this triangle, to this interdependence, this relationship between emotions and thoughts, and emotions and behaviors, and the relationship between thoughts and behaviors. Since we can't reach in directly and just throw a switch to change the way that someone is feeling, what we can do is look at how they're thinking. Is it fair? Is it balanced? Is there a different perspective they might be able to adopt? Or to look at the choices that they're making in terms of their behavior. How are they spending their time? Do they have this healthy mix of behavior? Do they have social supports? Do they have relationships? What are their stressors at their job, their environment, and so on? You want to help a person feel less depressed, you tackle one of these two areas. In general, CBT has a number of different stages, and I'll just talk about CBT for depression, where the first stage tends to focus more on what's called behavioral activation. Remember, when people are depressed, they become less active, they're more socially isolated and withdrawn. The first thing you want to do, though, is activate the patient, so you want to enlist them as a participant. This isn't the classic psychotherapy where the therapist just sort of sits there and looks very wise and says, This is active partnership, where you roll up your sleeves together and say, okay, I have this idea that your behaviors affect the way that you feel. But I don't want to tell you that. I want us to look in your life and see if that's actually the way it's going to work. So what I want to do is, just for a day or two, I want you to write down the things that you do. You don't have to change anything. If you stay in bed all day, stay in bed all day. If you watch old bad TV all day, just watch old bad TV all day. But write down what you do. And at the end of the day, I want you to rate your mood on a scale of 1 to 10. Do that for a couple of days, as many days as you want. Come back and see me and bring those results. And what happens, actually every time I've done this, and I've done this with hundreds of patients, is they bring back the results, sometimes 2-3 days, sometimes 8 or 9 days, depending. And they'll go, you know what? On days when I was more active, my mood was better. They have that light bulb go off. And they realize it doesn't take a huge event. They don't have to have a trip to Hawaii to improve their mood. Sometimes the change in activity is, I chose to take a shower today, and I felt better. And if you're not depressed, that may seem like, oh, come on, what is that? But even those simple behavioral choices, in sum total, we make hundreds of choices throughout the course of the day. The sum total of those behavioral choices can have fairly profound effects on our mood. Once that light bulb goes off for that depressed patient, they realize that they have some control. Depression's usually about thinking you have no control, you feel hopeless. Suddenly they have hope. They can start to make choices. The next step then is, okay, you've discovered in your own life for you, when you make certain choices, you feel better. Let's make a couple of choices in advance, do them, and see what happens. So you can see how this goes, and they become more and more active, they become less and less depressed. The next stage is usually looking at thoughts. We usually do behaviors first because it requires less concentration. With thoughts, they're actually capturing their thoughts, writing down their thoughts, and asking themselves the question, is this helpful or is this hurtful? Not is it right or wrong or true or false or good or bad. Is this helpful, the way I'm thinking about this situation, or is it hurtful? Is this balanced? It's not power of positive thinking. It's not rose-colored glasses, Pollyanna stuff. It's like, am I being fair? Am I remembering my past successes as much as I'm remembering my past failures? So it's a combination of changing those behaviors here and changing those thoughts, reversing those downward spirals, and pulling a person out of depression. Yes, CBT works for the alleviation of depression. People then ask the next question, all right, if we treat depression either with pharmacotherapy or with talk therapy, does it help things like cardiovascular disease? We know depression is related to cardiovascular disease. Can we reverse this whole chain of events that maybe happened? So this was a study called the Enriched study. They had CBT for depression, social isolation in patients who had had a heart attack. It was a number of different sites around the country. UCSF was one of those sites. Much to their disappointment, they found that there were no differences in terms of changes in cardiovascular outcomes. Yes, they got less depressed. Yes, they had better social supports, but they didn't seem to be able to reverse that chain of events, and it's unclear why that might have been. A number of other studies have looked at this. You got to wonder who comes up with these acronyms. This is the SAD Heart study, the sertraline antidepressant heart attack recovery trial. It's Zoloft, or it's an antidepressant. They found that it reduced serious cardiac events in post-heart attack patients by 20%. Was not statistically significant, though. They had a small sample. They were looking for much bigger effects. So again, that holy grail of showing that treating depression can actually reverse that change and decrease cardiovascular events doesn't seem to be true yet. There are a couple of indirect pathways which may help. We know that smoking and stopping smoking at any point can decrease your cardiovascular risk. We know that treating depression actually makes it easier for people to stop smoking. We also know that certain antidepressants actually decrease nicotine craving. So there's some relationship there that we haven't quite teased apart yet. So I hope you've seen through this sort of quick run through stress physiology, through anger and hostility, through depression, and ultimately just a very quick peek at some of those treatments like stress reduction or cognitive behavioral therapy, that yes, indeed, our emotions, the physiologic consequences of our emotions are absolutely related to disease, to most causes of morbidity and mortality. But the good news is, not only do we understand those relationships, but we're starting to reverse them. And I can guarantee you in the next decade, there's going to be some exciting research that tells us how to do this even more effectively. Thank you. So we have some time now for questions. Are there any questions? Okay, so the question was whether there is data linking emotions to medical conditions other than cardiovascular disease. That's the one we explain the most. That's why we often talk about it. Another example would be cancer. And people actually, since the time of Hippocrates, have been trying to prove that stress or certain types of personalities cause cancer. We really haven't proven that yet. We know that treating stress helps people cope with cancer and may help people recover. I don't think we've shown that emotional states can actually cause a person to develop cancer. There is, I think, a fairly well-established relationship between emotions and stress and immunity. So if a person is stressed, they're more likely to catch a bacterial-related illness or a viral-related illness. The only way we could maybe tie that to cancer, if someone is stressed, their immune function is down, they're more likely to, say, get an HPV infection. We know that HPV, human papillomavirus, is related to things like cervical cancer. So you could, if you work the chain out long enough, say that there's some relationship there. There's a number of other mind-body illnesses, things like chronic fatigue, fibromyalgia, irritable bowel syndrome, even exacerbations of asthma or a chronic obstructive pulmonary disease that we know can be related, maybe not caused by emotions, but certainly can be worsened by emotional stress. Yes. Right. So the comment in the question was about what I would call the illogic of our current health insurance system, where medical benefits and mental health benefits are often separated. You have to go through, even if you have, say, Blue Cross for your medical benefits, your mental health benefits are most likely managed by a different company called United Behavioral Health. Different rules, they limit treatment, you only get a certain number of sessions, so on and so on and so on. It makes no sense medically, biologically, scientifically to separate out those benefits. I think it's partly due to historic reasons. I think psychiatry wasn't particularly good at justifying their diagnoses of the treatments that they were provided. They weren't particularly good at limiting the treatments when the treatments needed to be limited. On the other hand, I think a lot of it's about stigma and discrimination. There's still a big stigma to mental illness. Even though your brain is an organ just like your heart or anything else, there's still a stigma to it. So people want to push it away, you know, out of sight, out of mind. Hopefully at some point we'll see a rejoining of medical benefits and mental health benefits. I don't see a champion pushing for that right now. And the healthcare system is such a mess, I think mental health is still kind of at the bottom of the barrel. Yeah. There's a lot, I think, of what we know in terms of the physiology, sort of the very clear sort of medical causes or consequences of depression. And I think it's getting harder and harder to say mental health and physical health are separate. We're understanding more and more about the genetics, even the physiology of schizophrenia or of anxiety disorders. So I think as our science progresses, it's going to get more and more difficult to justify this very archaic separation between what they call medical health and mental health. It's actually one and the same. It's just a different organ system. It's your brain, it's your central nervous system that has some sort of imbalance that's affecting the rest of your body. So my hope is that in my lifetime, at some point, we'll see sort of a rejoining of those ideas. Not quite sure how or when that'll come about, but I hope so. Yes? Sure. So it's called dysthymia, and it is a kind of a chronic low-grade depression. So clinical depression is oftentimes episodic. So it will last a few months, 6 months, might go away on its own, come back again later, go away, come back. Dysthymia is a lower level, and it tends not to go away. It's there at least 2 years, in fact. And some people would even say it's a depressive personality. Instead of having 5 of 9 symptoms, you have to have 3 of the 9 symptoms for at least 2 years with no period greater than 6 months when you were free of symptoms. So that's really kind of the depressed person that's always kind of depressed, but they're probably functional because it's on a milder level. So the question is, can a pessimistic personality be more prone to that? I think so. There's certain strengths to being pessimistic. A lot of good problem solvers are pessimistic. A lot of good artists, have this affective, this emotional ability. But yes, I think it does make you more prone to depression. So right behind you. I've heard some interesting theories about that. I don't think we've really moved it to a human level. It's more, I wouldn't say it's people, it's rat pups, and baby mice, and they give them very stressful, not really a childhood, but very stressful childhoods, and they see that there's greater sensitivity in their stress response system. So like their HPA axis that's responsible for cortisol, they are more likely to have elevated levels of cortisol if they've had an abusive childhood. There's been some similar stories in humans looking at adults who had abusive childhoods, and they tend to have higher levels of cortisol, and they're at greater risk for depression. So there is something that's going on. I don't know if it's dopamine receptors or not. I mean, that might be part of the picture too. So the question is a relationship between depression and autoimmunity, and autoimmune diseases, things like lupus or asthma, or when your body's immune system is actually too active. In general, you would think of depression as suppressing the immune system. So I don't know of a relationship between those two. I know people have tried stress reduction, they've tried treatment of depression. There is certainly an overlap between things like fibromyalgia and depression, but I really don't know the relationship between them. Are there gene-based therapies for emotional disorders? No, I don't think so. I hope not. It would, even for genetic disorders, that we're not real good with gene-based therapies yet. So I would really, at this point, I would worry about monkeying around with something as complex as our emotions. So it's sort of a chicken and the egg issue where we see these relationships where fibromyalgia, it's a chronic neuromuscular disorder. There are tender points where a person feels extreme pain. There's a lot of sleep dysregulation. It tends to co-occur with clinical depression. That doesn't mean depression causes fibromyalgia or fibromyalgia causes depression. It could be either way. It might be that it's the sleep dysregulation that causes both of them to happen. We don't really know right now. All the way in the back. Sort of the optimism gene or something. They've certainly compared cohorts, but they use questionnaire studies, and they follow them longitudinally over time, and they've shown all sorts of interesting things with optimism. You live longer, you get less illnesses, you make more money. There's all sorts of things. I don't think there's been a genetic study. It hasn't been that long since we just first cataloged the human genome, and we're still looking at really easy, small chunks of it. My guess would be something as complex as optimism, It's going to be a while if we ever get to the point where we can sort of pull apart a genetic signature that helps us understand that. Sure. So actually, Marty Seligman wrote that book. He was the guy I trained with at Penn, so I know it well and was one of the research assistants on that project. It was Penn's children's project, and what they did was go to the West Philadelphia schools, public schools, so it was low-income, underprivileged kids. They gave them a test measuring optimism or pessimism, just a pen and paper test. They then took the pessimistic kids, and half of them just got like after-school social hour, and half of them had a kind of a cognitive behavioral therapy. And they wanted to follow those kids over time and see if they could actually prevent depression, behavioral problems, improve their grades, and so on. And what they found was not only did the study work, it worked actually much better than anyone had thought it would. Those kids, and they picked 5th grade because they're right around pre-pubertal, but about to go through that crazy, difficult, awkward, emotional transition, and they wanted to try to inoculate them right before that happened. They found that the kids who went through the intervention, not only did it prevent depression, they had less behavioral problems, they stayed in school, they had less absenteeism, they had better reports of health even. So now the public school system in Philadelphia is funding a much bigger, I guess, dissemination of that program to all of their schools. So. That would be nice if we're going to invest in education, I think we have to invest in teaching kids how to have relationships and teaching them how to better understand and manage their emotions. So the kids were divided into 2 groups. One had an after-school therapy, basically like a cognitive therapy. And the other group, they watched cartoons and TV and hung out with adults there. And they did that because they just wanted to control for the amount of attention and time that the kids were getting. What they were doing during that time was quite different. But they just wanted to have them both in a captive audience and in the same place at the same time. So the one that had the therapy, the cognitive behavioral therapy, did better. So there's 2 things. There's really 2 chemicals we want to think of. We want to think of cortisol, but you also want to think of norepinephrine. And the immune organs, the lymph nodes and also the thymus, are directly innervated by neurons that release norepinephrine. So those immune organs can be either stimulated or they can be inhibited based on the firing of the sympathetic nervous system. So I think of sympathetic nervous system, but also cortisol on a more global level. Chronic higher levels of cortisol can suppress immune function. Right. Correct. Suppression of function. Yeah, it is, and I left that off, and the list I had, Paul Ekman gave me his slides, and that's from Paul. Some people say contempt is different from anger. There's sort of a different set of cognitions and feelings. I think of it more as a feeling because it's not just that physiologic sensation of anger. There's also this thought or this perspective of superiority. I'm so much better than you, you lowly worm. I feel contempt for you. You know, it seems like a higher level, higher cognitive function than a basic emotion for me. But I've seen the list sometimes including that. Right, looking at right, left hemisphere in depression. In terms of cause, not really. I mean, there's some research done looking at prefrontal cortex, so that's the brain right behind your forehead, and looking at left versus right prefrontal activation. And the simple answer is, in general, people who are angry or depressed, you see, if you're looking at, say, a PET scan or a functional MRI, you see more activity in the right prefrontal cortex. If a person's laughing, if they're happy, if they're enjoying time with another person, you see more activity in left prefrontal. I think that's probably a little too simple, but that's what we have now. People are doing studies like with meditation as a treatment for depression, and they're seeing that when the person meditates, they get more left prefrontal and less right prefrontal, which kind of makes sense. Okay, well, thank you so much for your time and attention. Appreciate it.